Good evening, everybody, and welcome to the 59th live webinar on orthopedic principles. Today, we have distinguished faculty, Dr. Anjani Singh, back with us. He's a consultant orthopedic foot and ankle surgeon at Liverpool, United Kingdom. Today, he's going to enlighten us on Achilles tendinopathy. Over to you, Dr. Singh.
Hi, good afternoon. Good evening to all in India and elsewhere. As Dr. Gopalan said, I'm Anjani Singh. I'm a consultant orthopedic foot and ankle surgeon at Liverpool University Hospitals. And I'm going to talk to you about Achilles tendinopathy, which involves both the insertional and the non-insertional subcategories. So just to go by definition, tendinopathy, or as otherwise known as tendinosis, is a general term that describes a localized intrinsic degeneration of the tendon collagen structure, which is characterized by an amalgamation of presentation, which is pain, swelling, and impaired performance, whereas tendonitis refers to a painful inflammation, which can histologically be proven with inflammatory cells within the tendon substance. So these two definitions sometimes are used interchangeably, but there has to be a broad difference between itis, which means inflammation, and pathy or tendinosis, which means more of a degenerative change in the structure of the tendon, which we tend to see more. So going by classification, it can be classified into different categories based on the duration, an acute presentation or a chronic presentation beyond 6 weeks. It can also be classified as insertional or non-insertional, depending upon the location of where the symptoms are. And as you see from here, it demarcates the areas where you would see them more commonly. Insertional is more around where the broad expansion of the tendo-Achilles attaches to the back of the calcaneum. And classic non-insertional pain is normally seen in what we call the watershed area, which is around 4 to 6 centimeters proximal to the attachment onto the Achilles tendon. And this again tells the rampant or the extent to which we can encounter these over a term. And it's seen here that the non-insertional variety is the one which is more prolific, and it accounts for around half of the pathology. So going by etiology, this again is divided into extrinsic factor and intrinsic factor. Extrinsic being due to poor surface condition, which would mean by ways of walking on uneven surfaces or different environment, poor shoe wear, so not well supported shoe wear, oversized shoes, also more common athletes with training errors, so not doing a proper conditioning or warming up prior to an activity, and of course overuse, which is again part of this active athletic people. In terms of the intrinsic factor, you can see more common in older individuals. With age, there's more chance of degeneration of the tendon. Postural problems that is encountered in foot malalignment or pes cavus or planus deformities, and also issues with decreased strength, flexibility of the tendon, as well as if they've got a cause of tightness of the gastrosoleus or the gastrocnemius tendon, or Achilles tightness that can culminate into a pathology relating to tendinopathy. And these all lead on to repetitive trauma, which continues. Initially, it is not noticed, and suddenly it becomes common with presentation with pain and swelling. And then you have microscopic injuries of the tendon structure with the collagen fibril being stretched, which lead to inadequate healing response and disorganization of the tendon structure, which presents with tendinopathic changes and symptoms. Another inherent cause, as you see, would be relation to the general health, which is more commonly seen with diabetics, hypertensive, people who are obese, are not able to maintain normal flexibility or have got more mechanical load on the foot, leading to malalignment or plus painus or tight gastrocnemius. There has been relation to exposure to steroids, which have got another bearing with collagen synthesis and affects that, and that can cause more decrease in the resilience and the tensile strength of the fibrils of the collagen. Advancing age, as we know with anything with age, things get less resilient and lose the tensile strength, they become more brittle, and so it goes with the tendon. They become brittle. And therefore they are not able to have that much healing response which you would expect from a normal individual or a normal aged individual. And also there is literature to suggest the exposure to quinolones, which is the ciprofloxacin antibiotics, which are supposed to interfere with the collagen synthesis by inhibiting the DNA gyrase. And this is quite commonly seen, and always it's a good idea to ask these questions when anybody presents with an acute tendon problem, rupture, or tendinopathic changes, to see if they've been exposed to any of these, which could be related to their symptom. Pathology, as mentioned before, the tendon becomes less resilient. It is unable to adapt to the sudden elongation, and is not as flexible to return back to its normal length, which leads to micro damage within the fibers, and the healing response is decreased, which leads to disorganization of the collagen fibers as well as the fibrils. They are not able to do that, and then it leads to degeneration, possible sometime culminating in cyst formation. And due to repetitive strain, this cycle continues, and then you get fragmented collagen, which leads to further problems with neovascularization of the sheet, which leads to more concerns with pain. And also you get more of these biochemical substances, which again contribute to the pain within the tendon, as lactate and glutamate. So how would they normally present? The normal presentation triad with, obviously with insertional, is pain and swelling, and also difficulty in walking for long distance. They cannot do the activity which they were doing before. Pain is quite prolific, can't walk for long distance. And this has all problems with swelling, as well as difficulty donning a footwear, which they were easily able to do before because of the constant rubbing at the back. So this is the Haglunds deformity, is a posterior superior prominence of the calcaneal tuberosity, and here you see the Haglunds triad, or the presentation with thickness of the Achilles tendon. You've got tendo-Achilles bursitis, which is the pre-bursa here, and then you've got the retrocalcaneal bursa, which is inflamed because of this prominence of the bone here, which is the edema in the calcaneum, which is part of the Haglunds deformity, which leads to wearing out of the tendon, and most of the time this area gets affected because of the constant friction. There is bursitis, and you can always differentiate between how much of the pain is actually due to the retrocalcaneal bursitis, or is it due to the insertional tendinopathy. So imaging for these, I mean, most of the time the presentation is of pain and swelling, and you can actually decipher where the pain is, whether it's in the mid-substance of the tendon or is it at the insertion. If you are further worried, or there's a risk that there could be an avulsion, or it could be you want to see if there's any calcification within the tendon substance, then imaging is necessary. But I normally don't tend to do that as the first line of treatment. First line of treatment is normal symptom management if they have an acute presentation. So you can look for X-ray appearance, which would show calcification within the tendon itself. Sometimes you have more enthesitis, which shows here calcification in that. Plus, you can look at the Haglunds prominence, which is this posterior superior prominence, and there has been various radiographic measures to look at that. And you can draw a line with the calcaneal pitch from the inferior process of the calcaneum going further, and then you can draw a parallel line, and anything which is excess of this is known to be a radiographic parameter for Haglunds deformity, also commonly referred as pump bump. So now moving on to the management of this condition. Of course, any treatment, even for the FRCS exam, the first treatment protocol would be a non-surgical treatment or a non-operative treatment. It also depends upon the longevity of the symptoms, and most common is rest and to reduce the activity which has initiated this. So like running, making sure you're resting the tendon to initially. Sometime you can use a boot, a walking boot, or a night splint, and you can also provide them with corrective insoles to try to offset if there is any mechanical malalignment in the foot, like if they've got a planus or a cavus foot. You can look at whether they can have well-supportive shoes, and you normally look at that for over 6 weeks. Although in the literature, there's nothing to demonstrate that this resting phase actually improves the condition, but it acts as a way of reducing the activity and maybe has some placebo effect. Again, the other mainline treatment is concentric or eccentric exercise therapy, which is normally if the patient is able to start off with. Initially, there would be some discomfort. It will be difficult to start immediately, but this is the main line of treatment in my practice. Is any of these acute presentations actually doesn't come to see me, they go directly to our specialist physiotherapist who look at them, and then they take them through an exercise regime for over 3 months' time. And there are some studies which have shown that concentric or eccentric movements have been found to be more beneficial for this, and also patients find them symptomatically much better. So again, saying that if you look at the literature, there has been a role identified for non-insertional Achilles tendinopathy for eccentric calf stretches, and that has to be for a period of at least a minimum of 3 months to carry on. And also this should be in line with any mechanical derangement of the foot as well as activity modification. The other line of treatment which has recently been popularized is the shockwave treatment, which is not available in all the settings, especially in hospitals across the United Kingdom. We do not have the facility in each hospital. Some units have them, and we have looked at this, and there's been numerous literature papers which have been presented, and there has been no long-term follow-up, and the literature is still not very supportive of this. Although it has been said that the tendinopathy does have time limit and is self-limiting, and if you correct the mechanical problems associated with it, it self-limits itself, which with an average period of over 24 months. So whether we are looking at the natural history of the disease, which is progressively getting better with time, or whether we are buying time by submitting them for shockwave treatment or the other treatment, which I would show you next, which is as a measure of progressing the time. So again, there is no hard evidence to suggest that shockwave treatment actually works. This is a medical treatment which is more based on the fact of increasing the vascularity, increasing the collagen synthesis, and trying to provide a reparative atmosphere within the tendon environment. But again, there is no firm evidence or scientifically proven evidence that this actually works. And some people do end up with not tolerating the drug because of vasodilatation and headaches. So further, corticosteroids, this acts as a pain relief, it reduces any inflammation, and blind corticosteroids is not recommended. I would recommend ultrasound guided injections, especially if you have an element of retrocalcaneal bursitis, which can be isolated by the ultrasound and then just injected in that area rather than in the tendon substance, because it has been proven that this does weaken the tendon structure and can reasonably cause rupture of the tendon. So the evidence of use is insufficient, and of course it has to be balanced in the fact that there is a risk of rupture of the tendon. So platelet-rich plasma therapy, that is PRP, it has been popularized, and it's been said that the Buffy coat, which happens after the centrifuge of the blood, actually contains quite a lot of growth factors, and the theory is that that helps in the repair phase of the tendon. But again, this has not been proven, and the evidence does not support this. Another thing is where we are using sclerosing agent, or what is known as prototherapy, which is high hyperosmolar solution of dextrose, which is injected under high volume and pressure to try to cause some tendon stripping, and in the process starting some cell migration into this area with fibroblast, as well as initiating a collagen synthesis mechanism. But again, this is not proven, and the evidence about this is not scientifically sound as yet. So going on the operative management. Now, this is a condition which obviously initial management is non-operative, and I would not recommend offering an operative management in the first instance, except for the case where you have got a profoundly hypertrophic Haglunds deformity, which is actually causing pressure effects on the shoes and everything. Then that is the case where you could look at that. But even then, you need to make sure that the other factors which could cause a similar problem have been ruled out and excluded. So I offer operative management for cases who have gone through all the non-operative phase and they have not had any significant relief after 6 months. And in that case, for insertional or non-insertional, I need to look at the substance of the Achilles tendon. Is that due to hypertrophy of the bone, whether I need to resect the calcaneum, or also how much degenerative tissue is there, how much of the Achilles tendon is actually viable rather than non-viable tissue. Because then it will depend upon how I counsel my patients, whether it needs augmentation, and most commonly I tend to use the FHL tendon, which again is a small tendon in comparison to Achilles, and patient needs to be aware, and their expectation needs to be brought into focus of what it will entail if you do an FHL reconstruction. So operative management, again, something which is commonly a normal procedure in sense that it is a straightforward procedure and it does not involve a huge lot of dissection, is to perform longitudinal tenotomies in the area where you feel that there's cyst formation within the substance. You mark it and you actually just dividing, doing longitudinal release along the tendon without dysfunctioning the tendon. And this is supposed to, this is for very mild disease or localized cyst formations, and that can help in around 60 to 70%, depending upon what the rest of the tendon is like. But it's not indicated in a severe tendinopathy. So debridement with tenosynovectomy, I have done that in the past if I feel that there is quite a significant affection of the tendon and this is formed, and along with cyst formation, then I go around and divide the tendon into longitudinal slits and then take off the diseased one, which I feel, and then I can tubularize it. So again, repair the remnant of the tendon. Now this can only be done if you can safely have over 50% of the tendon width. But if there's more than that, which you need to sacrifice, then you're basically dysfunctioning it. And in that respect, it's been said that we should augment that with an FHL transfer, which is just in front of the tendon and in phase. And that has given improved pain relief and also improved the functional outcome. And this is one of the things which have actually worked for me, but it has to be shown that the tendon structure is not uniformly degenerate, and it has to be some areas which are involved. And there is some evidence to support this treatment in the literature. So again, this is what I tend to do, is a posteromedial incision. We go down, we look at the tendon substance, we take the paratenon off, and then we look at the shininess of the tendon. And the way to demarcate is to use a wet swab and along the length of the tendon and see which areas really look less glistening. And those are the areas which you need to target for and try to debride it. And this is what is being demonstrated in this slide. And then that is what you're doing. So you are basically creating a longitudinal slit along the length of the tendon and excising the areas which do not appear healthy. I mean, in that respect, it's likely that you are not going to get rid of the whole disease process, because if it's in several minor sort of small focus, you are bound to miss some of it, but at least you're releasing the paratenon, and that has also got some evidence that it would decrease the pain for the patient. So this is what's been done. So that part of the tendon has been taken off, and then you're left with this, and then you stitch them over that. So you are trying to create a tubular structure. Now, if you take more than 50%, then you have to be aware that you should always look at augmenting it. And I always, whenever I go for this procedure, I do tell the patient and also consent them that there is a chance that I might have to use the FHL to augment it. So just looking at the level of evidence, I've been alluding to different treatment methodology, and this is what the scientific literature is about. And as you see on the slide on the left, there are various levels of evidence with the hierarchy of the scientific evidence from level 1, which is randomized control trial, and then level 5, which is more anecdotal experience. And then these have been graded according to grade A, grade B, and grade C and I, depending upon what level of evidence is supported for each of the different cohorts of treatment, which have been talked about before. And if you go on the slide on the right, it tells you grade A, which is the one which has got good scientific evidence to support it. And none of the options which we discussed before support this. Whereas grade B, there is some evidence, which is level 3 and 4 studies, which has suggested operative management for recalcitrant tendinopathy, which is by means of debridement of the dysfunction tendon. Grade C, which again is level 4 or below, eccentric stretching exercises, sclerosing injections, and chlorotherapy. These are the ones which are. So there's not a great deal of scientific support for these studies. And grade I, which is the one which has got insufficient evidence to actually make any recommendation. You can see what we alluded to before: shockwave therapy, corticosteroid injection, plasma-rich, platelet-rich plasma. So these all are grade I, which have got insufficient evidence to support or make any recommendation in the literature. So just moving on to the Haglunds, which is insertional, and you can see that that's the prominence there. And there has been some studies, and I tend to do that. I've not had a great deal of experience with this, but I have done a few resections, and you can do it in a prone position, and you can see that that scope goes in there, and you're pointing your scope looking at in the retrocalcaneal space. You can do some debridement of the retrocalcaneal bursa. At the same time, you can use your bone bar to shave that off, and you can always use X-ray to check how much off, how much part of that you have taken, because there's always a risk that you might take more, although we always tend to err on the side of taking less. Then the other treatment is the closing wedge osteotomy, which is supposed to change the alignment of the tendon by taking that off, and also a closing wedge, which reduces the pressure on the tendon. And this has been shown to work for some individuals, but again, it has to be decided of where the pathology is, and is it, and then the inherent problem could be that you're doing an osteotomy. There is always a risk of non-union or the bone not healing, although the calcaneum, I would say, does tend to heal quite well if we do like a medializing or lateralizing calcaneal osteotomy. And this is more biomechanically better because you are actually performing a closing wedge and a broad surface area of the calcaneum. This is which has been more popularized recently rather than doing a gastrocnemius recession. And this is something which has been supported now, and it has shown in people, especially who've got a tight gastrocnemius, the small release of the medial head of the gastroc does improve the pain in the heel. And that is what if you do have a tight gastrocnemius. So again, this would need to be isolated with your Silver Skull test to find out whether this is worthwhile doing in these individuals. And this is similar recommended for even people who have got recalcitrant plantar fasciopathy. There is evidence to say that this works in them as well. So as we talked before, position, prone, normally I tend to take that, and incision medial or lateral, we take the inflamed bursa off, and then we take that bit of extra bone off. And then we have to reattach the tendon, and there are various techniques of doing that. You can use the bone anchors, and you can use the speed bit technique, which is quite effective, and I tend to use them quite commonly. And then always have an idea of an FHL transfer in case you need to take a fairly large segment of the tendon. So again, as we talked about, less than 50% involvement of the tendon on table, then you can just debride it. Sometimes you can anchor the tendon onto the calcaneus if you have actually inadvertently detached it from the calcaneus. And you need to close the split, which I'll show you in my next slide. Whereas if it's more than 50%, then always go with a plan, or always go with a plan of doing an FHL augmentation. If you don't have to do it on table, that's good enough, but make the patient aware so that we don't have to regret not having told the patient about it. So this is what shows the incision. I tend to go directly posterior and get the tendon, do an incision in the central bit of the tendon and open it like a book, and then isolate the tuberosity, which is where the pathology is. And at that time, I debride the retrocalcaneal bursa, and then take off this excess bit of bone where it's easily demonstrated here on the Cobb elevator. And then you can use the saw to smoothen the surface, make sure there's no sharp points. And then that also offers a good cancellous bed to try to put your anchors in. So this is what is remaining, and you have created a smooth bed and rounded off any of the sharp points which would be there. And then you can see that the closes quite nicely after you decompress and taken part of that bone off. And this is what is, you attach the anchors. So I tend to use 4 anchors in a double row technique, and then stitch the tendon on that and then tighten it. And then you can close the ends of the tendon. This is the slide which shows an FHL. So in this case, if you have taken more than 50%, then you just go in the front and isolate the FHL tendon. You take it from the fibroosseous tunnel, so you've got reasonable length, and then you can see that this is the FHL tendon, and you can use your suture anchor, or you can use a bone tunnel and use an interference fit screws in there to also tensioning the tendon at the same time to ensure that this is tight in the tunnel. And then you can actually also repair the FHL muscle onto the tendon, which is supposed to give some blood supply. And because the FHL tendon has a long belly of muscle which comes quite low down, so that helps in the vascularity as well. And then you can retain the other part of the tendon, which which you have debrided and which is healthy, and close the tendon on top. And this is the slide showing the drill hole you're creating for the FHL tendon. And then you anchor that. So you're putting an interference screw, plus you've got this pull-through suture, which is where the tendon is being whip stitched into, and you pull that through the heel and make sure the tension is right. You can also adjust the position of the foot of how much equinus you want. I normally tend to do it in semi-equinus, and then I put the interference screw for the FHL2 in the bone tunnel. And that's stitched through there, and then you've got the leaves of the tendon there, and you can stitch that on top of it. So my post-op protocol is, if I haven't done a tendon transfer, I normally, and if I have detached the tendon and reattached it, I put the non-weight bearing with a mild equinus so that the tension of the soft tissues of the back is less. And then once the wound is healed, I get them into a weight-bearing cast, into a weight-bearing boot, weight bear as tolerated for 4 weeks, and physiotherapy starts around 6 weeks' time. If I do have done a tendon transfer in these cases, then I put them in a plaster with semi-equinus for 2 weeks, followed by a neutral plaster for 2 weeks. So that's 4 weeks. I just protect them. And at 4 weeks, they go into a boot for another 4 weeks, and then start physiotherapy at around 6 to 8 weeks' time. So again, operative management is not without risk. The biggest problems is the wound problem, especially the part of the area, the back of the heel. The skin blood supply is quite tenuous, and it can culminate with problems with wound healing. So I'm pretty sure that I don't mobilize them till at least the wound is soundly closed. And there's a lot of patients have been satisfied with this, especially if they've got a big posterior superior prominence and Haglunds, so insertional Achilles tendinopathy. Non-insertional, it's difficult to quantify because the patients do get better, but part of the disease pathology is still there in the tendon. And unless you do a whole en masse resection of the tendon, you would still have some symptoms ongoing. Again, risk of skin problems, superficial deep infection. I have noticed sural neuritis, although you do isolate the sural nerve at the time of the operation, but some of these patients present with this constant burning pain on the lateral aspect of their heel and going down the side of the foot. And that is perhaps because the sural nerve has been touched and has got irritated, but also because these patients can increase their dorsiflexion, and that sometimes stretches the sural nerve. But this does settle down, and I have seen in quite a few cases in which I have done this procedure. They can always have a re-rupture, and that's what, although with the new advanced double row techniques, the risks are less, but again, you have to tell them in your consent process. Weakness of plantar flexion, that's another thing you have to tell them if you are doing a FHL tendon or plan to do one. But I must say, I have not seen that, and not many people have complained about this being a problem after FHL augmentation of their Achilles tendinopathy. So I do mention to them, especially, it means you have to be very careful in athletes and in ballet dancers who rely quite a lot on their big toe flexion. Then of course this could be a problem, and you have to thoroughly take them through a proper consent process and counseling. But in most of the other populations, which is like elderly or sort of middle-aged, beyond 40, it's not really a problem. So again, going on the recommendation which I showed you for the non-insertional, this is for the insertional one, and it shows you, again, the level of evidence on the left with the grading, and as you say, non-operative strengthening exercise grade B. So that's, again, supported by level 3 or 4 evidences. Night splints is grade I, which is no sufficient evidence. Platelet plasma injections. And operative management is open debridement and decompression. That's the one we looked at, and that's got a grade B, which is fair amount of consistent evidence with level 3 and 4 studies. FHL tendon transfer is again an I, because we haven't got a huge cohort of people who have this surgery. Although there are some long-term, there are some new studies coming through recently published, which have shown that these do tend to work better in patients who have recalcitrant tendinopathy. And again, it depends how much of the tendon substance you have to take out. Gastrocnemius recession, and that's again grade I. So as you would see from this slide, there's not much scientific support for that except for open debridement and decompression. And of course, if you need to do like a Haglund resection or a calcaneoplasty, then that's something which would be suitable for patients if that's what their main cause of problem is. So that concludes my talk on Achilles tendinopathy. As you would have gathered, that there is quite a lot of evidence and a lot of pathology with a lot of various treatment options, but you again have to customize it to each patient and talk to them and ensure that this is a degenerative condition. It's degenerative condition. It's something which is tendon degenerative condition. It's not like a bone and joint reconstruction, which you can do a total hip or a total knee. So this is going to stay with them. And irrespective of even if you do a reconstruction, it would be more pain relieving, but they would not be sort of running a mile or going up and doing different high sort of manual labor jobs. So it has to be always said that you have to pre-warn them before you go ahead with any treatment strategy for these patients. Thank you very much, Dr. Gopalan. That concludes the talk.
Thank you, Dr. Singh. That was a splendid lecture, and we are very happy that you've quoted the level of evidence and the great recommendations for each procedure. There are a couple of questions that have come up. I'll just go through some of them. One is, do you prefer a midline incision or a slightly posteromedial incision for the open debridement?
I tend to skirt it slightly. So in the sort of proximally, I tend to go midline, but where the attachment bit is, I just skirt it around the medial side.
Okay, because bone complications are the biggest problem, isn't it?
Yeah, I mean, that's true, but I mean, it is. I mean, I must say I haven't had much of a wound problem, but it depends what sort of patients you have got. They've got other comorbidities, if they've got diabetes, circulation problems, smokers. Smokers is the biggest evidence with anything with foot and ankle. So I have to pre-warn them quite a lot, and they need to be aware before that. And sometimes I have to say if they can give up smoking, that is a plus point for any foot and ankle procedure. So I tend to go posteromedial more distally, but proximally over that area, I just go in the center.
Thank you. The other question is, what is the scientific basis for a percutaneous split, or a longitudinal split of the tendo-Achilles and the dorsal wedge osteotomy? Is it a tight tendo-Achilles?
I mean, the percutaneous split or the longitudinal split, as I said, is more in relation to and I tend to do it more regularly if I have got an imaging or an ultrasound evidence that there is mucoid degeneration and cyst formation in local areas within the tendon substance. And my feeling is that when you are doing this percutaneous split, you are in a way decreasing the pressure within the tendon. So it's like a compartment syndrome within the tendon, and you are actually releasing it. And also at the same time, you can get hold of these mucoid areas and you can debride them, and then you can retubularize that. So in a way, I mean, although scientifically it's not been said about anything, but my thinking is, and that's what some of my patients who present with fusiform swelling, I tend to send them for ultrasound just to see if the swelling relates to a cystic formation within the within the tendon substance. And if it is, then I counsel them and I say, okay, I think it will work. So, and I have had some good results, but that is only for localized pathology. If you have quite a severe disease process, then it's very difficult to cure the whole process or to get your patient back to normal.
The other one is regarding the osteotomy. You mentioned about the...
So the osteotomy is basically designed to, you are taking away or you are changing the direction of your tendon pull. And that is in a way you are, because if you look at what the slide showed was the tendon actually causes a lot of attrition on your Haglunds or the prominence. And when you change the orientation of the calcaneal tuberosity, that takes out the pressure over the back of the tendon. But I mean, some of these, I mean, I must say I've not I've not done these ones, and this is from the literature, and I don't tend to do them. If I do them, I normally do them arthroscopically and just do a calcaneoplasty rather than a whole wedge resection. But this could be useful in patients who have like malalignment, who've got a high calcaneal pitch, or who have got something like a valgus deformity, which you could manage at the same time. So you do a biplanar correction by offsetting there, so doing a medial displacement osteotomy, and at the same time taking a wedge from the top.
Okay. The other one is, how have you done a gastro recession in your practice? I mean, do you do the cervix cold?
I have been doing, I've not mentioned the gastrocnemius recession, but I have been doing that in the past. But now recently I've started doing the proximal medial gastroc release, which is much easier to do, and it's just a small incision. I tend to do them prone because I find it useful to identify the anatomy around the popliteal fossa, because you don't want to be going more medial because of the neurovascular bundles. But it's a small 10 minutes operation, and it is mainly for cases which where you have isolated a problem with gastrocnemius tightness.
So that's based on your cervix cold test, is it?
Yes, yes. I mean, if you feel, and even as I mentioned in my talk, even for you've got like plantar fasciopathy or plantar fasciitis, there has been recommendation of, if you have got a tight gastrocnemius, to release the medial head rather than do a plantar release and all, which in foot and ankle surgeon, I mean, it's quite debatable topic to do a release of the plantar fascia. So it all depends. You're addressing the pathology, and of course, that's what I said. You need to see a case on individual basis, and if they have a problem with the gastrocnemius, you can probably address that at the same time if you're debriding the tendon and all.
Okay, so in that case, medial gastroc recession is going to be a versatile operation, because in the right patient, it can address both the tendinopathy as well as a plantar fasciitis. Am I right?
Well, yes. I mean, that is if you've got both the pathology together. But I mean,
even otherwise, even if you have it individually, like what you said, you have a patient with a plantar fasciitis and you look at the tightness of the gastroc, and then
yeah.
it's an option. It's an option for a patient with plantar fasciitis as well.
It's definitely an option, and there are some new evidence recently published in the Foot and Ankle International there's a randomized control trial which looked at, I mean, we are slightly digressing from the topic of Achilles tendinopathy, but this is all plantar fasciopathy I'm talking about. And in that case, they've randomized to get medial head gastric release or doing a percutaneous plantar fasciotomy, which they have said. And they have found that the pain relief is much better with the medial head of gastric release. And it's a low demand operation, doesn't take any rehab intensively. Whereas if you're doing a plantar fascia release, that's a big one. It can actually dysfunction your foot, and it can collapse your arch and everything else. So it has got quite a lot of problems related to it. And therefore, in UK, most of the foot and ankle surgeons agree that we should not be performing a plantar fascia release for plantar fasciopathy. I mean, gastric release is perhaps the best option in a way, because you're not actually causing much of a problem to the patient. You're just releasing the fascia and reducing the tightness in their gastrosoleus.
And how is the incision that you do for the gastroc release medial? Is it a classic lazy S?
No, I just do a small. So I basically go prone, and you see the crease at the back where the knee creases, and I just go medial 2 centimeters, 2 finger breadths before the medial before the popliteal crease. Stay medial, and then if you just go through the skin, as soon as you go through the skin and deep fascia, you would see the white glistening plantar gastrocnemius medial head aponeurosis. And you have to be sure, because you've got the hamstrings coming on the medial side, so you have to isolate that and use maybe a Langenbeck or something to retract and ask your. So because it goes quite medial, you have to bring that down, and then you just under vision, just divide it with a sharp 10 blade. Make sure you don't go too lateral, because that's where your neurovascular bundles are. And most of the time you can ask one of your other assistant to keep the foot pushed in dorsiflexion. And once you release that, you sometimes can actually see that there is quite a significant gap in the muscle after you release the aponeurosis. So that shows that there has been a tightness, and because the medial head is quite thick, and also the aponeurosis is quite thick, that works quite well.
And is it a curved incision or a transverse longitudinal? What do you prefer?
I just do a horizontal incision.
Okay,
just in line with the crease. So you're parallel to the crease, and it's a small incision, 2 centimeter incision, and it's easy to close. Rather than giving an incision which is longitudinal, which would be easily noticeable at the back. And so, yeah, and you don't need a huge amount of incision anyway. There is literature to suggest a lot of people have been doing it under local. But of course, I have not been brave enough to do that as local. I normally do it as bring them into theater.
Yeah, because you need to be very clear of the anatomy, right? Otherwise, you may end up.
Yeah. Especially for people who are starting to do them now, it would be always useful to have your anatomy, and that's why I tend to do them prone. Although some people still can do them supine, because they normally tend to mix it with other procedures like supplemental procedures. If they are doing a flat foot reconstruction or something like that, then they do a calcaneal osteotomy and everything. So proning for them means that they need to turn them over to do the other procedures. So that it depends how you feel comfortable with.
And do you use PRP for any of these problems?
No, not really. I've not used PRP for this. I mean, incidentally, we did use PRP, but that was part of a NIHR trial, which was a national health trial, and we used it for ruptures, acute Achilles tendon rupture, and we were doing a randomized control trial on using PRP for people with ruptures, and we did publish it last year. It was published in the BMJ, and it didn't actually show much difference. So I think PRP, a lot of people say it makes difference, but I think it's an expensive thing. You need to, and then it's not funded universally in the National Health Service. Some of the private institutions do them regularly, and there is a charge and tariff on that. But I feel that it's not something I will use. I mean, it's fine enough if you want to keep patients away from having any surgical procedure. And again, it's a non-invasive procedure, and it might not lead to much harm to them, but whether it leads to a long-term benefit, there's no evidence to support it. And most of the times, if you address any other mechanical arrangement like stretching or insoles or correction of or releasing the medial head of gastroc, these are much more rewarding procedures in a way if you're adjusting to individual patients.
Okay, when you mentioned about insoles, do you just mean to just put a small heel insole? Is that a small one? Is that what you recommend?
Well, it depends upon individual patients. So I normally tend to prescribe them for individuals whom I feel that they will benefit, and it can be a small insole or it can be a full length insole depending upon what pathology is there you're addressing. If it's just a planovalgus with some tightness of the gastrosoleus, whatever, you can actually give them a 3/4, what we say, and you can use a medial posting on the side just to offload the lateral side and also built up, so get their arches built up as well. But if it's for cavus feet, then you again have to do a lateral posting. So it depends. You have to, and sometime I find if it's difficult, I normally tend to send my patients to orthotists so they can take a mold of their foot and then design the insoles from them. I mean, I don't believe in giving them off-the-shelf ones because I feel that it's different patients have different needs and different size of feet.
And does the orthotic guy, he looks at the feet pressures across all the areas in the foot?
We did used to have that. We had the pedobarograph, but now it's out of function. It's not working. So in places where we feel that would be beneficial, we tend to send them to an adjacent hospital where they have the facility and they do us for that. But I don't send each and every patient because that would be slightly more difficult for the service, which which they are providing to us at the moment.
Okay, Dr. Singh, I think that's all the questions that we have for today's program. Thank you so much for being with us. I mean, every lecture of yours is really enlightening, and I'm sure there are a lot of candidates today online, and I'm sure they're all benefited from this fantastic lecture of yours. And we look forward for more from your side. Thank you once again.
Thanks very much. Thank you for having me. Yeah, I'm happy to contribute anytime.
Thank you.
Okay, bye.